Hello, my name is Vicki Hudson, and I'm going to be your guide and moderator today. Thank you for joining our educational program entitled The Thoracic Oncology Nurse Practitioner's Role in Patients Living with Small Cell Lung Cancer and Lambert-Eaton Myasthenic Syndrome. This program is sponsored by Catalyst Pharmaceuticals. Please see the Catalyst Pharmaceuticals disclosure statement for both faculty today. Before we begin our discussion, I'd like to welcome and introduce our two expert faculty that we have with us today. Beth Sandy has been a nurse practitioner within the Abramson Cancer Center at the University of Pennsylvania for the past 20 years. She's been an oncology nurse for 25 years and specializes in the care of patients with lung cancer and head and neck cancers. She holds various editorial positions with oncology journals and newsletters and has been published in textbooks and nursing journals about the management and supportive care needs for patients with lung cancer. She frequently co-chairs and moderates regional and national conferences and speaks nationally on topics related to the care of patients with lung cancer. Good to have you here today, Beth.
Thank you, Vicki. I'm glad to be here today. These are my disclosures.
Thank you so much. Beth, can you tell us a little more about your clinical practice and your personal experience with LEMS in small cell lung cancer?
Sure. So my practice is patients with lung cancer, and within that, about 15 to 20% of those patients have small cell lung cancer. Now for LEMS, I've only ever had one patient over the past 20 years. It's a really rare condition, but we do find it sometimes, and it can be really hard to diagnose, and we're going to talk about that in today's program.
That sounds great. Thank you. And now I'd like to introduce Elizabeth Dennis. She currently serves as a nurse practitioner within Texas Oncology Baylor at the Charles A. Sammons Cancer Center in Dallas, Texas, and has over 12 years of experience. She is well-versed in offering evidence-based therapeutic care for her patients dealing with cancer and blood disorders. She is a collaborative and motivational leader with expertise in training new nursing staff while providing exceptional care to her outpatient chemotherapy and oncology patient populations. Good to have you, Elizabeth.
Thank you so much, Vicki. It's my pleasure. These are my disclosures.
Elizabeth, can you tell us about your clinical practice and patient populations?
Yes, of course. I work in an outpatient clinical setting, primarily dealing with solid tumors, more specifically in lung cancer patients.
Perfect. Thank you so much. And now we'll begin with our first segment, where we'll explore and take a deep dive into an overview of paraneoplastic neurologic syndromes.
So let's talk about paraneoplastic neurologic syndromes. Paraneoplastic neurologic syndromes are generally immune-mediated disorders that can occur in patients with cancer. And because we use immunotherapy in our patients with lung cancer, this can be problematic, and it's good to know about. About 10% of small cell lung cancer patients may develop a paraneoplastic syndrome. These symptoms may become apparent prior to even being diagnosed with the cancer. Detection of paraneoplastic syndromes can lead to early cancer screenings and early intervention for a tumor. So when these symptoms are present before the cancer diagnosis, it may help us diagnose patients earlier. Earlier diagnosis and treatment may improve patient clinical outcomes. So let's talk about some of these paraneoplastic neurologic syndromes in small cell lung cancer. The most common one that we see is Lambert-Eaton Myasthenic Syndrome, or LEMS, and this occurs in about 3% of patients with small cell lung cancer. The rest are also listed here and occur in about 1% or less of patients. Lambert-Eaton Myasthenic Syndrome is a rare immune-mediated disorder affecting the neuromuscular junction. It's characterized by muscle weakness, autonomic dysfunction, and areflexia, which is a loss of reflexes. About 50 to 60% of LEMS cases are associated with an underlying cancer, most commonly small cell lung cancer. The median age of onset in LEMS in patients with small cell lung cancer is about 60 years, which is a little bit younger than our average age of lung cancer, which is between 68 and 70 years old. Greater than 67% of patients with LEMS and small cell are men. 67% of cases with LEMS that are co-occurring with cancer are in patients with small cell lung cancer. You see about 10% in patients with lymphoma, leukemia, or thymoma, and then the rest are a myriad of other different types of cancers, some with adenocarcinoma. But by far the most common cases of LEMS that occur in cancer are in patients with small cell lung cancer. LEMS is a rare neuromuscular disorder that's often undiagnosed or misdiagnosed. LEMS affects an estimated 3,600 to 5,400 individuals in the U.S. Greater than 90% of LEMS in small cell lung cancer is actually undiagnosed. And then a lot of times it's actually misdiagnosed. 58% of LEMS cases are actually misdiagnosed. And we talked about that in the beginning for my patient with small cell lung cancer, who it took me a while to figure out why he was having such lower extremity weakness.
And now let's take a brief look at a video explaining the mechanism of disease for LEMS.
Control of muscle movement depends on input from the nervous system. The neuromuscular junction is the main site of this coordinated activity, relaying action potential signals from motor neurons to muscle fibers. Normal neuromuscular functioning requires appropriate transmission of acetylcholine at neuromuscular junctions. When an action potential reaches the axon terminal of the presynaptic motor neuron, acetylcholine is released into the neuromuscular junction. Acetylcholine binds to and activates acetylcholine receptors on the postsynaptic muscle fiber. Sufficient acetylcholine signaling initiates a sequence of events that results in muscle contraction. The action potential-mediated release of acetylcholine relies on the coordinated action of voltage-gated calcium channels and voltage-gated potassium channels. During normal neuromuscular transmission, an action potential causes a wave of depolarization as it travels down the presynaptic motor neuron. Presynaptic voltage-gated calcium channels open in response to the depolarization, allowing an influx of calcium. Increased intracellular calcium signals vesicles to fuse with the presynaptic membrane and release acetylcholine across the neuromuscular junction. Significant depolarization causes voltage-gated potassium channels to open and efflux potassium, repolarizing the presynaptic neuron. Repolarization leads to the closure of voltage-gated calcium channels, ultimately terminating the action potential and preventing further acetylcholine release until the next action potential. Patients with Lambert-Eaton Myasthenic Syndrome, or LEMS, have reduced neuromuscular signaling due to the presence of autoantibodies directed against voltage-gated calcium channels in the presynaptic motor neuron. These autoantibodies impair calcium influx during an action potential. Reduced intracellular calcium limits presynaptic vesicle fusion and release of acetylcholine across the neuromuscular junction. However, presynaptic stores of acetylcholine and the postsynaptic response to acetylcholine remain intact. Disrupted acetylcholine transmission reduces activation of acetylcholine receptors on the muscle fiber. Patients with LEMS experience diminished muscle fiber contraction and muscle weakness due to reduced acetylcholine transmission. Neuronal repolarization due to potassium efflux occurs as normal, ending the action potential before sufficient acetylcholine has been released.
So LEMS is progressive and debilitating. So the early recognition can really impact quality of life. As you can see on these Kaplan-Meier curves here, the orange curve is the patients who have LEMS and small cell lung cancer, and the blue indicates patients who have LEMS with no small cell lung cancer. And so you can see that the LEMS associated with small cell lung cancer tends to be more severe and progresses more quickly than a LEMS that's not associated with small cell lung cancer. And so that makes our diagnosis and treatment of this really important for the patient's clinical outcomes. You know, you can see that the leg weakness is pretty much the same for both, whether it's LEMS with small cell or LEMS without small cell. But all of the other ones, the proximal arm weakness, the dry mouth, the male impotence, this is definitely worse in patients with small cell lung cancer. So we can see here in the overall survival with the Kaplan-Meier curves that for patients with extensive stage small cell lung cancer, the solid line is the patients who have both extensive stage small cell and LEMS, as opposed to the dotted line represents the overall survival for just the run-of-the-mill extensive stage small cell lung cancer. So they clearly do much better if they actually have LEMS on top of the extensive stage small cell lung cancer. The same goes for patients with limited stage small cell lung cancer, where if they have LEMS associated with that as well, they have an improved overall survival versus the dotted line here showing the patients who just have limited stage small cell lung cancer without the LEMS associated.
Thank you, Beth. So I have a few questions for both of you. How often do you manage patients with neurologic paraneoplastic syndromes in your practice? And let's begin with you, Beth.
Sure. So for LEMS, I've only had one patient in my career. I've had a couple other patients who've had limbic encephalitis and another type of a paraneoplastic neurologic syndrome as well. So I've really only had 3 total, but I do remember these cases very well. They had very specific symptoms that were clearly outside of what we had worked up in their small cell lung cancer diagnosis.
Elizabeth?
As Beth said before, this is very rare, so I have not seen it in my clinical setting. However, we do focus a lot on neurological symptoms and review of systems, so this will be something that I train my upcoming nurse practitioners to look at.
Very good. Well, what are your thoughts on the impact of LEMS on quality of life and potentially on overall survival in patients with LEMS and small cell lung cancer? Again, Beth?
Yeah, I'll tell you, my patient who had LEMS was actually cured of his small cell lung cancer. He did very well clinically. He actually ended up living several years and actually ended up dying from colorectal cancer many years later. So this was something that I can identify with those statistics because he really did better probably than my average patient with small cell lung cancer.
Okay.
LEMS can significantly impact the patient's quality of life. Therefore, it's very important that we look for these symptoms.
You know, and I also think that it's hard to diagnose this. And so, you know, you said something earlier, Elizabeth, and I agree with you. I think this is something, after learning more about this topic, that I'm going to be more vigilant now, looking at my patients with lower extremity weakness and saying, hey, is this something that might not be the chemotherapy? It might not be their brain metastases, but maybe this is something with the LEMS diagnosis.
That makes a lot of sense. And now we'll be moving on to our second topic, which is what to do if you suspect LEMS and how best to conduct a differential diagnosis. Okay, Beth, let's begin with you.
Let's talk about LEMS clinical presentation, and we'll start by talking about the neuromuscular symptoms, which are really what we usually will commonly see first. And the proximal muscle weakness occurs in almost all of the patients, in about 97% of patients, and that's definitely what I noticed first in the patient that I had, typically even in the hip area. And then distal leg muscle weakness occurs in about 31% of patients. Oculobulbar involvement occurs in about half of patients. The proximal weakness in the lower limbs can present as an abnormal gait, and that's frequently what we will see. This is a very specific gait that we will show a video that will illustrate that. The weak muscles often will ache and become tender for patients, and they can have difficulty standing up from a seated position, climbing stairs, or walking. There's also autonomic symptoms such as dry mouth, which is really frequent in about 83% of patients, orthostatic hypotension, constipation, and male impotence as well. So how do we recognize LEMS during a routine clinical visit? Well, the weakness is usually the first thing that we will see. And a lot of times, like I said earlier, it can be confused with symptoms of small cell lung cancer or side effects from the chemotherapy. The weakness in the lower limbs, though, may present as this abnormal gait, and that's really where we see a differential from just a typical fatigue that patients may have. Also, that standing up from a seated position is also something that's sort of different than what we would typically see with just a side effect of fatigue in a patient. So that abnormal gait, difficulty standing, those are things that we might pick up on a routine clinical visit. So what are our diagnostic approaches? Well, we would test for this anti-VGCC antibody, and that can confirm diagnosis. That would be a blood test, and or doing an electrodiagnostic test, which is a high-frequency repetitive nerve stimulation or post-exercise facilitation test. That can also be a confirmatory diagnosis tool. LEMS may be suspected based on clinical symptomatology and physical signs, but we really need to do one of these confirmatory tests to make a definitive diagnosis. So testing for the presence of this anti-VGCC antibody is supportive of a LEMS diagnosis. There's 2 different subtypes. We can see the PQ subtype in the predominant mediator of the neuromuscular transmission. And this type can be detected in about 90% of patients with LEMS. A less common type would be an antibody against the N subtype, and that can be detected in about 30% of LEMS patients. The N-type antibodies are often seen with LEMS associated with cancer. The PQ-type antibody are highly specific to LEMS, but have been reported in 1 to 4% of patients with small cell lung cancer, even without neurologic dysfunction. Sensitivity and specificity of the VGCC antibody tests may be affected by the source of the antigen and the specific laboratory performing the measurements and testing techniques utilized. So while a positive anti-VGCC test can support a LEMS diagnosis, it should be noted that a negative antibody test does not rule out a diagnosis of LEMS, and electrodiagnostic testing should be performed as a follow-up. So when we differentiate LEMS from small cell lung cancer with CNS involvement, so this is something also that came up in our conversation, Elizabeth. So approximately 80% of patients with small cell lung cancer will unfortunately develop brain metastases. And about 60 to 75% of patients with brain metastases present with neurologic symptoms. Even 10% might have seizures. So it's hard sometimes to differentiate here, what could be from brain metastases versus a LEMS diagnosis. I think one of the main differences here would be that gait abnormality and the ataxia, which is present in 15 to 20% of patients with brain mets, but really is indicative. Remember, it was like up to 90% of patients with LEMS. Also, with LEMS, we probably wouldn't see the nausea, vomiting, the headache as much. So the obvious, though, for me is that we would, do testing to see if there's brain mets there. And then when there is not brain metastases, then I would be looking more for something like a paraneoplastic neurologic syndrome, such as LEMS. The other thing that we see in small cell lung cancer is patients with leptomeningeal disease. Leptomeningeal disease is when there's circulating cancer cells within the meninges. And so with this, we frequently will see headaches, back pain, nausea, cranial nerve deficits. You can see gait abnormalities, but I wouldn't say that's one of the first things that I see in patients with leptomeningeal disease.
The NCCN guidelines for small cell lung cancer currently includes the recommendations listed on this slide. For patients with small cell lung cancer and symptoms that are indicative of Lambert-Eaton Myasthenic Syndrome, or LEMS, including proximal muscle weakness and autonomic dysfunction, a neurologic workup, preferably in consultation with a neurologist, is recommended. This workup may include, but may not be limited to, tests for PQ and N-type voltage-gated calcium channel, or VGCC, antibodies. Early subspecialty consultation should be considered for unusual paraneoplastic neurologic syndromes to ensure the most appropriate management is done.
So when we talk about nursing management, the recognition of the paraneoplastic neurologic syndrome by a multidisciplinary team will definitely be the best way to support our patients. Again, I am not working in neurology, I'm working in oncology. So I definitely would want to get these patients referred pretty quickly to neurology. We know that these LEMS symptoms can be really impactful for the patient's quality of life. So we want to make sure we're asking them about how much immobility are they having from it? Are they able to perform their own self-care? We need to make sure we consider their physical, psychological, social, spiritual, and other practice requirements that this could be affecting for patients. So really doing a full needs assessment is really important when we suspect or diagnose LEMS or any paraneoplastic neurologic syndrome. Making sure that we're referring to other healthcare professionals, maybe not only just neurology, but possibly things like physical therapy to help with other physical and practical capabilities that the patient may be suffering from.
What challenges do you think you or other healthcare providers may experience in the diagnosis of LEMS? And let's begin with you this time, Elizabeth.
That's a great question, Vicki. I think the rarity of this LEMS disease is number one, what we face, not seeing it, clinicians not being familiar with it. So education is key. I think the video we showed is a great tool to utilize in all of our areas so that people can become more educated on this disease.
Okay, Beth?
Yeah, and just the fact that it mimics other things that we could see in patients with small cell lung cancer. The symptoms of this can initially mimic brain metastases or leptomeningeal disease, side effects of their treatment. So just being able to first make sure that's not what it is. Get your MRI of the brain to make sure they don't have brain metastases. Work up the leptomeningeal disease, make sure that's not it. And then I think once we've, ruled those other things out, this has to be something that's on our radar now to say, oh, this could be LEMS, and this could be really affecting them.
Have you seen patients with waddling gait as shown in this video, and how helpful is this in recognizing potential LEMS patients?
No, that's a great question. As we discussed before, I have not seen someone in clinic with LEMS and this waddling gait. However, this video should be a tool used for our clinicians to educate them on the ability to diagnose this disease in a more timely manner.
Yeah, for me, what I do remember was that he was in a wheelchair because he was really weak in the legs. And so I may not have made him get up and walk. And now I think that's something I will do with patients. If patients are telling you they're having this leg weakness, particularly the proximal leg weakness up by the hips, which is not typically something patients would, call out, right, then I would want to see them walk, because that's a really diagnostic tool. I feel like what we saw in that video, that's different than anything else that I would really see.
That makes a lot of sense. How do you test for neurologic PNS and/or LEMS in your practice? And do you have an order set?
We do not have an order set within our clinic. However, we would refer them out to neurologists that work closely near our clinic.
Okay. Beth?
I've never ordered the antibody yet. In my only patient, I wasn't actually sure what was wrong with him, so we did send him to neurology, and neurology worked him up for us. I think that probably after watching this program, now I understand what I might need to order, so I could, probably order that test. We don't have an order set in place. I mean, this is, again, something that's pretty rare still. But I was thinking about this, and, if we ever, did start looking for this earlier, this is something potentially we could have our nurse navigator put an order in place for us.
And now we're going to take a look at a small cell lung cancer patient case and get a detailed view from each of you outlining the steps to consider.
So this is our patient. She's a female, age 66, with a 40-year history of osteoarthritis, and she's also having significant anemia. She's a current tobacco smoker. She smokes a pack and a half a day for over 50 years. Her other comorbidities include hypertension, hyperlipidemia, and COPD. Her initial complaint is that she has significantly worsening fatigue, a dry, non-productive cough, and worsening lower back pain that's different from her typical arthritis discomfort. So at the urging of her family, the patient goes to the emergency department.
Upon ED cancer screening and testing, a chest x-ray was done where a large mediastinum opacity was seen. Chest CT, 4.5 centimeter subcranial lymph node with enlarged right hilar mass, measuring 2.6 centimeters, and bone metastasis in L3. An oncology consult was requested. A bronchoscopy revealed small cell lung cancer. A brain MRI was done with no evidence of intracranial malignancy. Pathology did confirm small cell lung cancer with a typical IHC profile.
Based on the information so far, what might you suspect in this patient?
Well, I think this is a very typical workup of a patient with small cell lung cancer, very large mediastinal mass, and that's a big lymph node there. It's really typical of what we see. I think the one thing that would concern me in this patient is that sort of severe fatigue that she's having. It looks like she has a bone met at L3, and we would want to probably get an MRI of that and make sure there's no, spinal cord compression there. But likely there probably isn't, and so in that case, she has not been treated yet. Now she does have some anemia, but usually we're not going to see such severe fatigue, and I'd want to know more about why she's having such fatigue and do the workup for that. So for this patient, continuing on with our case study, we would treat her with etoposide, carboplatin, and immunotherapy. That would be our typical first-line treatment. Her cough and shortness of breath improved dramatically, and that's typical. This is a very chemosensitive disease, small cell lung cancer. But her general weakness, initially that was attributed to the anemia due to the chemotherapy, she does end up getting a red blood cell transfusion, but that resulted in really no improvement in her weakness, and I think that would really concern me right there.
How common are similar symptoms to patients you see in your practice, Elizabeth?
That's a great question, Vicki. We see these patients with these symptoms on a daily basis. Patients receiving treatment for small cell lung cancer typically will present with these symptoms.
If you were to diagnose a patient with LEMS, how would you implement a multidisciplinary care plan for this patient, Beth?
Well, certainly the first thing is to consult neurology and get them under the management of a neurologist who really understands this disease better than we do and is treating the patient appropriately. But I also think for this patient, you know, they're now dealing with significant weakness in their legs and their arms. So we have to, you know, get an understanding of how is this impacting their daily life. Do they need a visiting nurse? Do they need physical therapy? They probably are going to need an assistive device like a walker or a wheelchair. So we have to make sure that we're sort of looking at all aspects of this.
So additional testing and screening was done. We repeated the brain MRI to evaluate for brain mets, however it was negative. We did a lumbar puncture to test for leptomeningeal disease, which was also negative. We considered potential neurological PNS, and an anti-VGCC PQ and N-type tests were ordered. VGCC antibody testing was positive. A neurology consult was made where they found profound weakness in proximal legs and the arms. The patient and the family reported a significant decline in her gait and ability to perform her usual activities. Neurologist performed an electromyography test that did confirm LEMS.
How are we going to manage these symptoms and treat this disease? So the clinical improvement can be seen just from the LEMS in response to the cancer treatment. However, we don't always want to just bank on the fact that the cancer is getting better just from the chemotherapy alone. So really symptomatic treatment is recommended in addition to the anti-cancer therapy. So immunomodulatory therapy can provide a short-term benefit in the management of LEMS, and it's recommended for flares or when symptomatic treatment really is insufficient. So symptomatic therapies that increase availability of acetylcholine, such as amifampridine, or inhibit the degradation of acetylcholine, such as pyridostigmine, are also treatment options and may provide improvements in muscle strength. So in conclusion with our case study, the continued symptom management for LEMS, the patient has tolerated it well and has remained with limited symptoms. The patient's quality of life has increased significantly and she is able to perform her ADLs. So how would I manage my LEMS patients? Well, first, assess the small cell lung cancer patients for potential weakness, difficulty standing, or irregular gait. And by that, we would actually have to make our patients stand up and walk. And that's an important thing. Sometimes our patients are actually wheeled back into the room, and if we don't actually get them up and walk with them, we're not going to know. So that's one important thing that I'm going to take away from this. Consider that the LEMS in any patients with weakness that's disproportionate to their disease. So for example, in our case study, this patient had an L3 met, but really on the scans, you know, we did the MRI, we did the lumbar puncture, and it was not showing that there was any significant leptomeningeal disease. So that was really disproportionate to what she was reporting to us. If LEMS is suspected, definitely order that paraneoplastic panel or the VGCC testing, and then engage a neurologist to help you confirm that LEMS diagnosis. Once the LEMS is confirmed, then use what we have for LEMS management, such as amifampridine, or immune modulating therapy, such as IVIG, plasma exchange, prednisone, and other treatments that may be available if the patient is only having limited benefit from the amifampridine. So our take-home messages are that we need to promptly identify LEMS and appropriate screening for small cell lung cancer, and that can help improve the outcomes of both the lung cancer and the LEMS. We need to make sure that patients with small cell lung cancer and a paraneoplastic neurologic syndrome, including LEMS, have improved survival, so we need to make sure that we are identifying it early and knowing what to look for. The brain metastases and the leptomeningeal disease can present with similar symptoms, so it's important that we know the differences, and then that we recognize and treat the LEMS, which can also then help their quality of life.
What are two of the most important things you would tell your peer thoracic APPs at UPenn and Texas Oncology to remember about LEMS in small cell lung cancer?
Great question, Vicki. I think I would tell my staff to ensure that they're doing a thorough review of systems, to make sure that if a patient comes in complaining of musculature weakness, that we watch them ambulate, we watch them get up from the seated position, and that we educate across the board. The second thing I would tell them is to get a quick neurological consult, because these patients often go undiagnosed.
Yeah, I would agree. Just making sure that we're doing a better neurologic exam and making them walk, because You know, I think we have to start thinking about like lower extremity weakness. Is it proportionate to their disease? And if it's not, then we should be working this up. And then I think the other thing to know is that there's actually a treatment available for it. So I remember back, over 10 years ago when I had my patient with LEMS, we really didn't have treatments for this. We were just kind of piecemealing together what we thought we could use. And now there are better treatment strategies for LEMS. So there's something that we can do for them.
And that is good news all around. Thank you for participating in today's educational program on Lambert-Eaton Myasthenic Syndrome in small cell lung cancer. We've explored clinical presentation, pathophysiology, diagnostic strategies, and current management options for LEMS, with a particular focus on its association with small cell lung cancer. Recognizing the early signs of LEMS and understanding its paraneoplastic implications are crucial for timely diagnosis and improved patient outcomes. As clinicians and healthcare professionals, staying informed and vigilant allows us to better support our patients through earlier interventions and more personalized care strategies. We hope this program has provided you with practical insights and reinforced the importance of interdisciplinary collaboration in managing complex syndromes like LEMS. Thank you again for your attention and your commitment to advancing patient care.